Dr. Smith is an internationally renowned speaker and author on the subject of metabolic, anti-aging, and functional medicine. Dr. Smith is currently the director of the Center for Personalized Medicine and the co-director of the master's program in metabolic and nutritional medicine at the Morsani College of Medicine at the University of South Florida. Dr. Smith is an author of numerous best-selling books and is a diplomat of the board of the American Academy of Anti-Aging Physicians. And I just want to say, welcome, Dr. Smith. Thanks for being here.
Well, thank you so much.
Yeah, and let me first just say kind of how excited we are to have the chance to collaborate with you recently and some of these recent changes we've done with our testing.
It's been very exciting. One of the things I really enjoy about teaching about hormones is really looking at the science behind it. A lot of times people feel that really we don't need to measure hormones, there's no science, it's not reproducible, and all of those things are totally not true. This is a very scientific way to look at hormonal therapy.
Great. And do you mind speaking just a little bit about your history and working with us at Genova Diagnostics?
Absolutely. I've been using your lab actually for just short of 20 years. So even when it was back to Great Smokies. Your lab is fabulous. They are extremely accurate and reproducible. Now, how do I know that? I know that because several times my staff and I have done specimens and we have split them and sent them out, and they are totally reproducible. We get the same results.
Before starting any sort of hormone prescribing protocol, what would you say is the most important thing to know?
Well, the most important thing to know really is the body and really prescribing hormones. How much does the patient make in a day? You know, for a male, he makes 4 to 8 milligrams of testosterone in a day. For women, well, women are much more complicated. And I don't say that lightly. I have 5 daughters. Women are more complicated, so we need to know really what the levels are that women and men make throughout the day. And it's very important to understand the steroidogenic pathways and to really understand that cholesterol makes pregnenolone, which then goes on to make the estrogens, progesterone, testosterone, DHEA, and cortisol. And if one of those hormones is out of balance, then really the hormonal symphony does not play in tune. We have to go back and rebalance those hormones so that the entire steroidogenic pathway is a great symphony. Start low, go slow. So let me give you an example by going back and looking at what women really make in a day for hormones. So these are the 24-hour production rates of sex steroids in women at different stages of the menstrual cycle. So for example, women, as we all know, make more progesterone mid-luteal phase. So the most that the woman makes is 25 milligrams. To do another example, testosterone. She makes the most testosterone pre-ovulatory, but that's 171 micrograms. How about estradiol? She makes the most pre-ovulatory as well, 380 micrograms. And we do know that when the patient, particularly transdermally, applies hormones, they get absorbed very, very well. The dose response curve has been done. And so we want to be physiologic. We want to be scientific about how we give hormones because they really need to balance. And so starting out by going slow and knowing what the 24-hour production is in a patient will help guide us in the dosages that we should be using for optimal health for the patient.
I see. And, another thing that you talk about is the importance of balance. And, what do you really mean when you refer to balance in that way?
Well, it really is all about balance. To give you one example, people commonly don't think about it, but estrogen has to balance with testosterone. So if the patient doesn't have enough estrogen, and we're not going to replace it, for example, hormonally related breast cancer, then if testosterone's low, we don't want to replace that without replacing estrogen. Because if you give testosterone and estrogen is not there, or the level is not optimal or balanced, then you increase plaquing in the vessels of her heart and increase her risk of having heart disease. So we commonly talk about estrogen and progesterone balance, but the same thing for women, estrogen and testosterone have to balance as well. Another example with estrogen and testosterone is that testosterone for women does help with memory, but it only helps if estrogen is there first. To give an example for men, if we give men supra-physiological doses of testosterone, then it drives up insulin. The other hormones in the body get out of balance. So hormones for both men and women, it really is all about balance.
Yeah, and that's really interesting, given how much testosterone therapy is being utilized today.
It is, and really that's why it's so important to always test. No one would give thyroid medicine without measuring thyroid, and people should not consider, as prescribers, giving hormones, sex hormones, without doing a salivary test. Very, very important.
And on that comment, when you're managing a patient with hormones, how do you normally utilize testing in your practice? What do you find to be the most applicable?
Well, having done this for many, many years, my approach has changed. What I used to do is see the patient, order the tests, bring them back, go over the saliva test and blood work with them, and then see them in 90 days. And if it's a woman that's menopausal or a male that's andropausal, I would just see them once a year. Having done this for a long time, once a year is not enough. So what I'd like to suggest to everybody is that you see the patient, order the studies, bring it back in to discuss, then repeat the saliva test in 90 days. It does take 90 days for the hormones to balance themselves, and then every 6 months thereafter. Because if you do it once a year, you will find that changes occur and the patient doesn't have optimal health. We continuously monitor patients for forever. It's never a time really when I wouldn't stop testing for her. I personally, you guys make a lot of tests at Genova that are grand, but I personally love for women that are menopausal getting the E1, the E2, the E3, progesterone, the testosterone, DHEA, and I always get cortisol. I always get the cortisol. And I love doing that 4-point cortisol. That's 8 in the morning, 12 noon, 4 to 5 p.m., 11 p.m. at nighttime. And I love the variance that you have in testing, because the one day is great for menopausal women. But when women are younger, and we're looking at PMS, PCOS, infertility, postpartum depression, and it's really important to do the Rhythm Plus, where we look at 28 days, 11 specimens out of 28, to really see the whole hormonal picture. Very, very important. Mm-hmm. Also, the 6-day test is great for a perimenopausal woman. If she doesn't want to do a 28-day test, then if she's still cycling and she's perimenopausal, I will at least do the 6-day test, where we start on day 16 of her cycle. We're trying to catch ovulation, because if she's still cycling and we only do one day, if that one day happens to not be representative of really what's going on with her throughout the month, then it's going to be hard to balance her hormones.
This next slide here, we have our new therapeutic range cover page that we had the privilege of collaborating with you to develop. Could you say just a little bit about the cohort that was used for this therapeutic range cover page?
Yes, basically this was a cohort of women from ages 37 to 62. They were all on hormonal therapy, and we looked at their estrogens, E1, E2, and E3. We looked at progesterone, and we looked at testosterone and DHEA. In these cases, the estrogen and testosterone were transdermal, as they always should be. The progesterone was PO, and the DHEA was PO or oral as well. The way to read these tests, really, you can see on the screen. For example, the estradiol is 5.3. That's really not dead center of normal. We are kind of shooting for dead center of normal. So here, the patient's only in the 30th percentile. We'd really like to get them to the 50th percentile so that they're all balanced. So would this particular menopausal woman with the estradiol, which is still there, need a little bit of estrogen? She would, to bring her up to that 50th percentile.
And lastly, can you just speak a little bit to the importance of personalizing therapy for patients?
Well, as you just mentioned, our practice is called the Center for Personalized Medicine. So it really is now in 2016 and will be in the future in medicine all about personalization. It truly is. And that's so great because it's not Star Trek medicine. We really have the science now to customize and individualize therapy for every single patient. To give you an example of my own self, when I was premenopausal and perimenopausal, I was very estrogen dominant. So it took 300 milligrams of progesterone PO to balance the amount of estrogen that I had. Now that I'm menopausal, I use Bios cream E2 and E3, and now I only need 110 milligrams of progesterone PO to balance the estrogen. So it does change throughout the patient's lifetime. Sometimes we need more hormones when we're under stress, so there may be a time where she needs a little more. Commonly, women after the age of 70 may need a little less hormone to produce the desired results. So you really can customize and individualize or personalize for the patient. One size does not fit all.
Thank you so much for your time, Dr. Smith, and for spending some of that with us. Just wanted to mention that for our listeners, for additional resources, you can learn more from Dr. Pamela Smith in these books listed here. And you can also register for our live GDX webinar where Dr. Smith will present case studies in the management of the menopausal patient. And, just thank you again, Dr. Smith.
Thank you so much.